Hi everyone, we're back for part 2 of section 1, and we are on chapter 9 talking about CVA. So a stroke, also called a cerebral vascular accident, causes an acute onset of neurological deficits caused by the decreased blood flow or bleeding into localized areas of the brain tissue. We know that stroke is the 5th leading cause of death in the United States, and the rate of stroke is found to be highest in the Southeast United States. Healthcare costs associated with strokes are quite significant. The average healthcare cost per person, inpatient and outpatient, for strokes has been estimated at anywhere between $8,000 to $16,500, and that does not include additional cost of morbidity-related expenses, lost time from work, additional nursing care, etc. And the direct and indirect costs to our nation are estimated at $33 billion. But there are factors that can be divided into modifiable and non-modifiable risk factors. Age, sex, race, ethnic origin, and hereditary have been identified as non-modifiable. Some important modifiable ones, though, include risk factors for hypertension, cardiac disease, diabetes, increased cholesterol, smoking, illicit drug use, and lifestyle factors. So there's a 4-fold increase in stroke when a patient is hypertensive with a BP greater than 160/95. And studies show with treatment for the hypertension that there's almost a 40% reduction in the stroke. So pathologically, there's 2 types of strokes. We're going to briefly talk about ischemic and hemorrhagic. So cerebral ischemia is caused by the decrease in blood flow to the brain, particularly in the cerebrum. Ischemia can further be divided into thrombus, embolism, and hyperperfusion. So briefly, thrombosis is the local obstruction of an artery, and common causes can be atherothrombosis, dissection of an artery, or disease of the arterial wall. And embolism, we know, is the fragments of debris that travel downstream and can include smaller arteries and arterioles, producing areas of ischemia. And then decreased brain perfusion can cause syncope, and if the perfusion remains low, such as during cardiac arrest or shock, that there are neurons that begin to die. So next, the next type in our pathology is cerebral hemorrhage, and neurological symptoms that are associated with this can be the result of the pressure from the hematoma, and this can infarct the compressed tissue. On cerebral hemorrhages, there's 2 types: epidural hematomas, and these are usually caused by severe head injuries, and they are most common along the temporal cranial wall and result from tears in the middle meningeal artery. And then a subdural hematoma is bleeding that is caused by a blunt trauma that knocks the brain against the skull. There are also intracerebral hemorrhages, and these hemorrhages are referred to bleeding within the brain parenchyma, and one of the most common causes of this is hypertension. Then also there's subarachnoid hemorrhages, and these are caused by tears in the arteries running along the subarachnoid space at the surface of the brain, and these ruptured arterial aneurysms are the most common source of a subarachnoid bleed. So if you have a patient that presents with a sudden onset of focal neurological signs and symptoms, the first thing that needs to be considered is a stroke. Information for the history and physical exam will assist in identifying the areas of the brain involved, what the etiology of the stroke is, and determining whether the stroke could be hemorrhagic or ischemic. Important things to include in your history is the nature of the onset, the timing, duration of neurological deficits, and whether the deficit is remaining, whether it improved or it worsened. It's also important to know what activity was going on when the symptom began, the severity of the symptoms, and whether the symptoms have worsened, improved, or remained the same. With these patients, there needs to be a thorough neurological exam, as that helps localize the type of stroke. And on page 120 and 121, there's signs and symptoms that are typically seen based on the type of stroke that you might be considering. So be sure and review those. Also, time is of the essence. Patients who present within a few hours of the stroke symptoms may be eligible for acute stroke treatment with a plasminogen activator and requires an emergent evaluation. This is going to include vital signs, a stroke scale, blood glucose levels, head CT, and assessment for any contraindications. Diagnostic tests, other ones that can be included would be MRI, EKG, chest x-ray, non-contrast CT of the head, CBC. Our main goal is to maintain adequate tissue oxygenation. The main principle of management for stroke patients is to prevention and early recognition, so that we're able to treat. If there's concern that the stroke has just occurred, then the patient will be sent to the emergency department. Follow-up is very important because the main goal is rehabilitation to return the patient to the optimal level of functioning. The rehab process involves 6 major areas of focus, and that includes prevention, recognition, and management of any comorbidities, training to make them as independent as possible, to help with coping and adaptation for the patient and the family, prevention of any secondary disabilities, enhancing quality of life, and prevention of recurrent stroke or any other vascular conditions such as an MI that can frequently occur with stroke patients. On page 125, we have the iceberg of a stroke. So I encourage you to look at that and see how, all the components such as pharmacological, caring, mind, body, education, environmental, diet, psychosocial, rehab, and surgery interplay to help manage the care of stroke patients. All right, we're moving on to the last chapter, chapter 10, infectious and inflammatory neurological conditions. First, we're going to talk about meningitis, which is an inflammation of the meninges that surround the structures of the CNS system. This inflammation can be acute, subacute, or chronic depending on its cause, and causes can include infection, neoplasms, autoimmune issues, and drug-induced. And one common factor seen with all of types of meningitis is the increased number in white blood cells found in the CSF. You can have both viral, while those are the most largest number of cases. There can also be bacterial and fungal infections that can occur. Organisms that may impact bacterial meningitis include strep pneumoniae, Neisseria meningitis, and H. influenza. On page 127, there is a table 10.1 that talks about the different types of meningitis, and it breaks it down into the type, whether it's bacterial, chronic, or viral, and then classifies all 3 of these according to description, organism based on age, diagnostic test, and treatments based on age. Most of these patients present with a headache, being sensitive to the light, and neck pain and stiffness. Some objective signs that you will see with meningitis indicating meningeal irritation include the photophobia, pain with eye movement. They can have Brudzinski sign, which is hip and knee flexion when the knee is flexed, or Kernick sign, the inability to fully extend their leg. Good history is very important, as it can yield many clues to the possible causes of the meningitis, and these major areas to emphasize include pertinent exposures, recent infectious symptoms, evidence of being immunocompromised, systemic disorders, and travel history. So with your patient, if meningitis is suspected, that's a referral for an immediate hospitalization and extensive workup and exam and treatment by neurology. And the goals will be to eliminate infection, giving symptomatic care and prevention complications of treatment. Next, let's talk about encephalitis, which is an inflammation of the parenchymal brain tissue. And symptoms include fever, other systemic signs of infection, depressed level of consciousness, seizures, and focal neurological signs. There is overlap between meningitis and encephalitis, and they can occur together, which is meningioencephalitis. Viruses are the more common cause, and although non-viral, bacteria, parasites, chemicals, and autoimmune reactions are also possible causes of encephalitis. These patients may present with confusion, changes in level of consciousness. They may have symptoms of meningeal irritation, such as the headache or stiff neck. They may be lethargic, and there may be behavioral or personality changes. If encephalitis is suspected, these patients need to be referred to neurology or transported to the emergency room for further evaluation, as there will be need to have cultures obtained in a further workup. Treatment will include antimicrobials, supportive care, and preventing any complications. Next, let's talk about herpes zoster, also known as shingles. And we know that the varicella virus becomes latent in the neurons of the ganglia after primary infection with chickenpox, and then reactivates later in life in a dermatomal area. 1 in 3 individuals in the U.S. will develop shingles. The patient will often present with unexplained pain that can be described as tingling or a stabbing quality, and the pain usually occurs about 48 to 72 hours before the eruption of a vesicular skin rash along that dermatome. It's important that if you have shingles that are along the trigeminal nerve, that there is the complication of herpes zoster ophthalmicus. I know I butchered that, excuse me, but that can be a very dangerous condition and should be referred for immediate evaluation by an ophthalmologist. Diagnosis is usually made by history and physical, and the main goal is to help manage the vesicles until they are healed, help with pain relief, and prevent any secondary infections or complications. Treatment of choice is your acyclovir, your valcyclovir. Some thoughts have been said that systemic cortisone therapy may reduce acute pain in conjunction with the antiviral. It's important to assess for herpetic neuropathy, which is a persistent pain that results from shingles that lasts more than 3 months after the disease has run its course. It's more severe in individuals ages 50 and up, and can occur in more than 1/2 of untreated people age 60 and older. Next, let's talk briefly about trigeminal neuralgia, which is a painful disorder of the trigeminal nerve, cranial nerve number 5, and it's described as an excruciating facial pain that is sudden and usually lasts less than 3 seconds. It's more frequent in women and in older individuals. Patients complain of a sudden severe pain to the side of the head, and the patient history will include that they can have trigger points that can be stimulated by chewing, talking, brushing their teeth, touching their face, etc. On examination, it's important to assess cranial nerves, especially the trigeminal nerve. These patients will present with facial muscle strength and reflexes that are normal. This condition can often be diagnosed based on clinical history, and especially when it's described as the sudden pain episodes that are triggered by specific activities in patients that are typically older than 50. Patients who have prolonged episodes of pain with increased intensity and occurrences and are younger need to be evaluated for secondary causes such as tumors, trauma, MS, or other vascular compromise. The CT scan and MRI could be done. MRI is the method of choice in determining trigeminal nerve pathology. Initial treatment is the management of pain, and carbamazepine and gabapentin have been proven to be very effective in the neuropathic pain. If that is not controlling pain, then tricyclic antidepressants such as amitriptyline can also be used to treat the pain. Next, we're going to talk about Bell's palsy, which is issues with cranial nerve 7, and you will see lower motor neuron facial paralysis, and is typically on one side of the face. The facial the peripheral facial palsy is usually self-limiting, and most patients have complete recovery in a few weeks to months, and this is typically seen in 80 to 86% of the patients. Typically, these patients are unable to make movements on both sides of the face if you ask them to do something. So if you ask them to raise their eyebrows, wrinkle their foreheads, close their eyelid, whistle, or smile, they're only able to do that on one side of their face. As we mentioned, the majority of patients will recover without treatment, although some feel that treatment with steroids within the first few days of symptoms help improve the recovery and is recommended. During this time of recovery, it's important that you assess or make sure that your patient is assessing their eye, because Bell's palsy can cause weakness in eye closure, especially during nighttime. So it's important that the eye is protected from injury, and it may need some lubricating drops and may need a patch at nighttime. Follow-up should be at regular intervals to assess that there is resolution of the palsy and or no deterioration in the symptoms. Next, let's talk about Guillain-Barré, which is an acute monophasic immune-mediated polyradicular neuropathy. It's usually an ascending paralysis, most often beginning in the legs, that progresses upward. Patients report tingling in the extremities. Management includes IV gamma globulins or plasmapheresis. And our last slide, we're going to talk about myasthenia gravis, which is a disorder of the neuromuscular junction. It's an autoimmune disease in which antibodies target the receptors for acetylcholine at the neuromuscular junction. It's more common in younger women and older men greater than 60. It can cause muscle fatigue and weakness, and eye movement and speech are commonly affected. Treatment is with anticholinesterase agents, immunosuppressive drugs, immunoglobulins, and plasmapheresis are also used to reduce antibody levels. And last, multiple sclerosis is a chronic disabling demyelinating disease of the CNS that often begins in young adulthood. Common symptoms include visual changes, weakness and numbness, and loss of balance. It's the most common cause of disability in young adults, and there are 3 classifications: relapsing remitting, primary progressive, and secondary progressive. The most common presenting symptom in MS includes weakness of the legs, bowel and bladder dysfunction, an ataxic gait, numbness and tingling to the extremities, and optic neuritis. Management of the condition is to delay the progression of the disease, manage chronic symptoms, and treat exacerbations. Glucosteroids are treatment for acute exacerbations. Patients with relapsing remitting MS may benefit from early aggressive treatment with disease-modifying agents, and these can reduce the frequency of exacerbations but do not necessarily decrease the long-term disabilities. These medications can have many possible adverse effects, so it's important to have this patient in with a provider who is familiar with the condition and the medications and their side effects. On page 142, there is medications commonly prescribed for multiple sclerosis, and these include both injectables, oral medications, and symptomatic medications. So I encourage you to review those, what their indication is, their prescribing considerations, and any adverse reactions. And that is the end of this chapter and section 1. Thank you for your time.